My name is Dr. Paul Richardson, and I'm the Director of Clinical Research at the Jerome Multiple Myeloma Center in Boston, Massachusetts, and I serve as the R.J. Corman Professor of Medicine at Harvard Medical School. Now, the second presentation that I wanted to share with you was from our work basically evaluating the very exciting CD38 targeting antibody isatuximab. Isatuximab is in the same family as daratumumab in that it targets CD38, but what's very important is that the antibodies do actually have qualitative differences. For example, isatuximab is better able to target the ectoenzymic pathway that CD38 subserves on the myeloma cell surface, and also at the same time have more of an apoptotic effect, as well as perhaps, certainly preclinically, have different effects on the immune milieu in which the tumor sits. Whilst both antibodies are clearly exquisitely active in terms of their antibody dependence, cytotoxicity, and other features such as T-cell activation and indeed macrophage activity, one interesting property between the two antibodies is that whilst daratumumab activates complement, and that obviously can be helpful, but it does lead to some concerns about the respiratory side effects of first infusion. Interestingly, isatuximab doesn't have that same effect on complement to the same degree, and so seems to be associated with less frequent respiratory type reactions. Early phase data had shown that isatuximab had very similar activity to daratumumab as a single agent, and so we launched a phase 1b trial combining isatuximab with pomalidomide and dexamethasone. I had the privilege of leading this with my co-investigator, Dr. Joe McHale. And we were able to show that in this trial, not only was the combination very well tolerated, but at the same time, not only also was the response rate high, but the median PFS for this large trial was striking at over 17 months. This provided the backbone for the Icaria phase 3 trial, which was a much larger phase 3 comparison of patients with relapsed refractory myeloma, where pomalidomide and dexamethasone would be the appropriate standard regimen. And therefore, we looked in this population to compare that approach to isatuximab, pomalidomide, and dexamethasone as a comparator. The trial involved 300 patients. It was conducted in 26 countries, 92 centers, and we were able to rapidly enroll the study, 150 patients per arm. They truly reflected a real-world relapsed refractory population. Over 90% were lenalidomide refractory. About 20% were high risk by cytogenetics. A significant proportion had renal impairment, and also we had a broad age range with a significant proportion of the patients being over the age of 65. So putting this all together, we then evaluated the 3 drugs versus the 2, and I should mention that in the study we did allow patients with asthma and COPD, which was an exclusion for patients entering daratumumab-based trials because of this respiratory concern. And we were very pleased to see that when you administered isatuximab weekly for the first month, and then every 2 weeks thereafter with minimal pre-medications and a relatively short infusion time, that these patients not only tolerated the infusions well, with a low rate of very low rate of discontinuation, and an overall infusion rate reaction of around 30%, which was typically within the first infusion and not thereafter. But we were also able to see a very manageable safety profile. What we saw with isatuximab was some neutropenia, some higher rates of chest infection, but these all proved generally manageable. Now, the really striking thing was the PFS difference that we saw, which approached 12 months for the 3 drugs compared to approximately 6 months for the control group. And that to us was particularly striking, so almost a doubling of PFS. What was also important was that the response rates approximately doubled in favor of the 3 drugs. And what was then particularly interesting is that this was already translating with a median follow-up of under a year into a survival benefit for the 3 drugs versus the 2. When we did subgroup analyses for risk categories, we showed that the renal impaired patients, the 3 drugs performed particularly well. High risk, they performed particularly well. And very importantly, in those patients who are lenalidomide refractory and lenalidomide was part of their last regimen, the isatuximab PomDex platform generated a hazard ratio of 0.5, which is very favorable. So in aggregate, this was the first phase 3 of its kind to be reported to date, looking at this very vulnerable relapsed refractory population, very much a real-world population, and we show clear clinical benefit for the 3 drugs, isatuximab, pomalidomide, and dexamethasone, over the current standard of pomalidomide and dexamethasone. I think this builds very nicely on previous experiences where we've shown, for example, in the Optimism trial that pomalidomide, bortezomib, and dexamethasone was an ideal platform in patients who've had prior lenalidomide and become refractory to it, but in a less advanced setting. And so to now have this particular 3-drug platform potentially available for our patients, I think, is a very exciting new direction.